How do you respond when colleagues say these patients just don't want to participate in trials or they don't want to be randomized?
I hear that and I understand when my colleagues say this is just so hard to do. We can't recruit patients to do this. And in my own experience, I recognize a challenge, but I also recognize a necessity. And I realize that it's not a them problem, it's an us problem. That we need to understand how best to approach people, how to overcome ambivalence, concerns, how to answer questions, how to think about the trust equation, particularly the historic background for different populations. Some populations have right to be ambivalent, to be dismissive even. And what we have to do is recognize that if our goal is to answer pertinent questions with evidence that allows us to guide best practices going forward, this is a pause moment where we take the time to first listen. And that might be the issue. If we just start by saying, I want you to sign this and not listen first, and I know that takes time, perhaps that's the way that we do this. And experience says that it's going to require more work, probably reaching out to two or three times as many patients to get the same number, but the work is worthwhile. Would love to see what Dr. Stone says about this because doing clinical trials and doing them well is one of his several areas of exquisite expertise. Greg, what are your thoughts?
Well, thanks. This is really one of the areas where you have to be a physician. You've got to be a caregiver, and you've got to have the same kind of relationship when you're trying to consent a patient into a clinical trial that you would when you want to take care of them. Because the reason that we're asking a patient to trust us to enter a randomized clinical trial, especially one of two very different therapies, like PCI versus CABG, is to either improve their own outcomes, which we can never guarantee, or to at least generate the kind of evidence that's going to help them give us knowledge to be able to better take care of people that are like themselves. Or it could be family members, it could be friends, future generations, et cetera. And I very much believe in the goodness of people, but and I think people do want to help. But to get them to have that level of trust in us, we have to look them in the eyes. We have to sometimes take their hands, and we have to explain to them that the reasons that we want them to engage in a trial where they might be randomized, taking the decision of how they'll be treated out of their hands, is truly being done for the right reasons, with the best of all intentions. And in this case, it's helpful to let them know, of course, that these are both FDA approved procedures. There's nothing really investigational here, that we just don't have the knowledge of how to choose one therapy versus the other to fit the situation that they are in, where both might be applied at the beginning. We let them know that by being in clinical trials, there's going to be many people that are watching over them very closely, more than their usual caregiver team. They're going to be calling them. There's going to be frequent visits, et cetera. And that we're not withholding one therapy or the other from them. We're just deciding which goes first and that the other one is always available. And I think that if we can spend the time, if we can make the bandwidth in our own lives to sit down and have what is often a 20, 30, or 40-minute discussion with a patient, to give them all the materials that we've created, patient-facing materials with stories that are being told, again, of patients like them. Let them speak with their families. Let them come back in several days. This shouldn't be a rushed scenario to get an answer that most people will, develop that trust level and will want to participate. But it takes time and it takes effort.
Well, I couldn't agree with you more. It takes time and effort, and you got to be willing to try more than once.
You do. You do.